Hello and welcome to this channel. This is from Geriatric Medicine Department, Medical College and Hospital, Kolkata. And in this channel, we junior residents of this Geriatric Medicine Department will start one by one video on the various topics of geriatric medicine which can be relevant to both non-medicos and medicos. And in this very first video, we are going to discuss about geriatric oncology. You will get to know why we have chosen this geriatric oncology topic as a very first of our videos. And I am Dr. Abhijit Noshkar from Medical College and Hospital, Kolkata, now making this video after attending the SIOG conference that you will all know. The International Society of Geriatric Oncology 25th conference was held in Ghent, Belgium this year as geriatric medicine. So some other statistics that can be important in this regard, that is from ICMR data, approximately 48% of new cancer cases are from geriatric age group, and almost 54% death annually due to cancer belong to this geriatric age group. So half of all cancers are in older adults, and it contributes more than half of the deaths annually in our country that belongs to this geriatric age group. And if you just want to know what are the common cancers in geriatric age group, definitely males and females are different cancer, and one of the most important is definitely lung cancers, followed by oral and health, head and neck cancer, followed by gastrointestinal cancer including gallbladder cancer, colon cancer, and definitely prostate cancer in male. And particularly in female, there is breast cancer, gynecological cancer including cervical, ovarian cancer, and definitely there is very important preponderance of thyroid cancer in females also. And the reason is quite common in all parts of our country. Tobacco, both in smoked and non-smoked pattern, is a very important contributing factor for this prevalence of cancer in our country, followed by metabolic syndrome, diabetes, obesity, and unhealthy lifestyle, along with unequal access to screening and treatment. So all these can be the contributing factor for this surge of cancer in our country. And next, if we want to assess why geriatrician should be included in the team of oncology management, we know there is a team approach for this type of cancers nowadays, and definitely medical oncologist, surgical oncologist, radiation oncologist, along with palliative physicians are included in this aspect. But unfortunately, due to lack of awareness in our medical field and obviously non-medical field, there is no access to geriatricians. So we should be very clear that at least for geriatric cancers, a geriatrician should be incorporated in this team so that the outcomes will be actually very different from the usual outcome. And this is the main focus of this video, why a geriatrician should be incorporated in comprehensive team management of oncology. And among them, the most important thing one geriatrician can do, that is the assessment, overall assessment of a patient. And the one important tool that we geriatrician use is CGA, Comprehensive Geriatric Assessment. There are multifactorial points that we give to our patients, and based on this point we can assess whether this patient is frail or weak, or the patient is fit and is eligible for chemotherapy or other radiation therapy, etc. And there might be a very unique features of this CGA, that age is not a marker of frailty. we give other factors to be important, and based on this it is seen that approximately 80-year-old a patient, he or she can be very much fit compared to a 65-year who has multiple comorbidities, and his or her frailty index is quite higher than the 80-year-old guy. And so it is a job of geriatrician who can actually assess the overall comprehensive health status of this patient, and based on this he or she can comment on whether the patient should receive chemotherapy or radiotherapy. And the outcomes will be definitely an important change in this outcome. We see in all of our background study that if CGA is done, and based on this the treatment outcome is definitely different. The moral of the story is that age is not a factor at all. In our ageist theory, we always give emphasis on age, age, and age. But as a geriatrician, we should remember that age should not be a marker of frailty at all. We should give the individualized therapy for each of our patients, and any patient of higher age group 80 or 85, if he or she are fit to receive this therapy, they should definitely get it. We are often biased that our 80-year-old patient cannot undergo surgery because just he has the age of 80. This is not true at all. It has been seen that if we perform our CGA like tool very precisely and the patient is found to be fit, he or she definitely undergo that surgery for the definitive treatment. At the same time, when a 60-year younger geriatric patient we are receiving, we think that everyone is fit for chemotherapy or radiotherapy. He or she might not be. At least she or he can get that palliative care instead of that chemotherapy. This chemotherapy can actually worsen his or her lifestyle. So this is an important message that geriatrician always should be there in the team, and he or she should give that final decision whether the treatment should be undergo for this patient. One important thing here to mention that in our practices, particularly in OPD practices, in a busy OPD, we are not able to calculate the CGA for all of the patients because it is a multifactorial thing, and there will be definitely a new video regarding this CGA. We'll get to know why I am so interested in CGA and I am so emphasizing about the CGA. But there is a shorter form of CGA that can be included for geriatric oncology purposes to quickly assess the patient. So any patients having some kind of cancers, particularly for geriatric age group, when we will receive the patient, we'll definitely do this screening tool, that is G8, and there is 17 score. If we get less than 14, the patient is vulnerable to have some frailty, and for these patients less than 14 out of 17, we should definitely do a complete CGA. Otherwise we can just skip this CGA if the score is more than 14. So this is an important tool, G8, and it has been established that G8 has very important prognostic factor for cancer screening, for frailty screening in cancer patients. It has been seen in almost all data and studies that has been done based on CGA that CGA can make striking difference in the outcome of treatment in these geriatric oncology patients, and there is relevant data that shows that frailty is definitely a prognostic marker of this treatment outcome, and frailty is not actually based on age. We might think a 80-year or 90-year-old patient is more frail than a 60-year-old patient, that is not actually true. And here lies the job of a geriatrician, who will decide who is frail and who is not frail, who is fit to receive the chemotherapy or radiotherapy and who is not. And it is a very important decision because it has been shown that the overall toxicity based on the chemotherapy received by the patient is more in elderly people. So it is the job of geriatricians to decide whether and what approximate dose, this dose adjustment is to be consulted with the geriatrician. And this is a now established theory in all over the world that a geriatrician will be incorporated while the treatment guidelines is followed for a patient. And that is the reason for this video, to enlighten all of our medical professionals that geriatric oncology cases should always be included by a geriatrician. And there are various challenges in our system, definitely, because as we are approaching for 20% of populations being geriatric age group, but there is a very shortage of geriatrician. Approximately 1000, less than 1000 geriatricians are there, and there is only few seats available for MD courses. So there is definitely a very large gap in supply and demand, and the time and manpower constraint is always there. There is definitely socio-economic barriers, because if not, we cannot expect that everyone will get this facility, because definitely it is a matter of economical burden also. So in government or semi-government sectors, we can expect a geriatrician to be incorporated in this team, but in private setup, definitely that is a matter of time. And definitely there is limited palliative care integration also. So a geriatrician will always decide whether this patient should get definitive treatment by chemotherapy, radiotherapy or surgery, or the patient should only get palliative treatment, because it has been seen when the more frail patient receives the chemotherapy, the overall median survival is less than not receiving the chemotherapy at all. So it is a job of geriatrician to decide whether this patient should at all get the chemo or radiotherapy, or the patient should undergo palliative or end of life care. So this type of taboos should be broken by the geriatrician only, and that's why the importance of geriatric oncology by the geriatricians.